Happy New Year, everyone. My name is Dr. Valerie. I'm the medical officer in the palliative unit. I'm introducing the speaker, who is Dr. Nafula. She's a palliative care specialist, currently heading the pain and palliative care unit in Kenyatta. Dr. Nafula is passionate about palliative care, having previously worked as a volunteer in Coast, Kakamega, and Nairobi hospices. She has worked in the field of palliative care for 7 years, with roles including pain management, education in palliative care, and service provision for patients and families.
Hello, Dr. Valerie, we seem to have lost you. Hello, Dr. Nafula, Dr. Valerie, we seem to have lost you. Our apologies for that. We seem to have lost Dr. Valerie and Dr. Nafula, who are presented today, but they are getting on board just right now. So as we're saying, as she was saying, she was introducing Dr. Esther Nafula, who has done a lot of work in the palliative care sector and who's going to be our main speaker today. As we try to get them back on, we welcome you once more to this session, to this webinar session this afternoon. And we welcome you to participate, to give your questions, your comments at the Q&A section. And we'll be able to have that session at the end of the presentation. So in a bit, they'll be joining us.
Sorry for the interruption, a bit of network problems. So we want to talk about pain assessment, because pain management starts with proper assessment. Failure to assess patients' pain properly means that we are going to undertreat the pain, or we are not going to be able to identify the pain that the patient has. So the objective is basically for us to understand the methods that are there for assessing pain. Now, pain is a very subjective experience. The way one person experiences pain is not the same way another person experiences pain. Therefore, assessment will largely rely, and of course, in many cases, it's exclusive, on the use of self-report and the reports we are gathering from the patient. It should be an ongoing process. It's not a one-off thing. It should be individualized and documented, and the documentation should be standard. So we aim to use the same assessment method or assessment tool on the same patient every time we are assessing or reassessing their pain. And of course, the description of pain starts by us asking the patient to tell us about their pain. We don't ask the caregiver. We don't ask their neighbors. If it's a child, don't ask the parents. If the child can communicate, start with asking the child. So research has shown that simple routine documentation of pain levels does not lead to any improvement in the quality of pain management. So simply writing the patient is in pain today, reports pain today, it doesn't help. We need to do proper assessment every single time. If you are assessing or reassessing, you have to do it properly. And the goal is usually, of course, to assess the pain properly before giving treatment, and to give the treatment also time to work before we can reassess. So remember, the important thing is to question the patient. The patient is the one feeling the pain. They're the ones who know what pain they're feeling, how they're feeling it. So engage with the patient. Use an appropriate pain rating scale. We are going to go through them in the next few slides. Evaluate the behavior of the patient and their physiological signs. Now, why this point is here is because culture, socialization affects the way we rate or rather respond to questions about pain. If you meet men, for example, in Kenya, they'll tend to underrate their pain, and it's because of our cultures. Our cultures say men should not cry, men should not feel pain. Therefore, you also need to observe how is the patient's behavior. If it's a child, the child might be afraid that you're going to prick them. They might be afraid of upsetting their parents. So they might want to underrate their pain. Then secure the family's involvement. Remember, when a patient has pain, this pain, if it's severe, for example, it will keep the patient awake at night. It will interfere with their activities. It will interfere with their relationship with their family members. So it's good once we've identified where pain is coming from or what the cause of the pain is. It's also good for the family to be involved, to know that this is the cause of pain, this is the treatment plan, this is what to expect long term. Then take action and assess effectiveness of your action. So taking action means choose an appropriate analgesic to manage your patient's pain, and then assess the effectiveness of the therapy you've chosen, and of course within a timely manner. Pain is the reason why many patients come to hospital. So even if we are investigating and trying to find the underlying problem, remember to actually manage the patient's pain, because that is what has brought them to you. So again, we cannot emphasize enough, but the single most reliable indicator of the existence and intensity of pain is the patient's self-report of pain. The patient will give you a lot of information about pain, and it should be your primary source of information. It is more accurate than the observation of others. If I tell you I'm having a headache, you, by looking at me, you cannot know that I'm having a headache. But I'm the one who is having the headache, I'm the one who is experiencing it. So our primary source of information should be the patient. Now, the American Pain Society has guidelines for treatment of acute and cancer pain, and they suggest that when doing assessment, we should do three things. First is get the patient's self-report of pain. You chart, where possible, display it in the patient's medical records, by their bed. This is the tool they have used. This is where their pain is. Then the intensity of pain and discomfort should be assessed and documented at regular intervals. Now, there's no blanket statement like pain should be assessed every 10 minutes, 30 minutes, or every day. It depends on the type of pain the patient has presented with and the circumstances. For example, if a patient is preoperative, they're going to get a procedure. Postoperatively, the pain is assessed differently from the patient who has come with metastatic cancer and has been having pain for maybe 2 months. The assessment and reassessment intervals are different, but they need to be regular. Then the degree of pain intensity is measured after allowing sufficient time to pass in order to ensure that a specific pain intervention treatment has occurred. So if we've given our patient a morphine injection, for example, the information you need to have is what is the onset of action of morphine, when will it reach peak concentration, and when do you expect the medication to be cleared from the system, so that you know at what intervals should you expect pain, or after how long are you going to add more pain medication for the patient. Because sometimes we found patients who are over-medicated for pain because they are not responding to one intervention. But the question is, did we allow sufficient time for that intervention to work? Now, when assessing pain, the three main issues are history taking, clinical examination, and relevant investigations. So you start off with a history. You want to know more about this pain, and that's the point at which we will use the assessment tools. Then examine the patient and see the site where they're saying there's pain. Is there any other pathology? And then what investigations does the patient need? And remember, please relieve the pain even as you're doing your investigations, because from history and clinical examination, you can be able to make an impression or a clinical judgment of what is causing the patient's pain. So relieving their pain is okay as investigations go on. So now when we come to the history, we start by asking where is the pain? So the site of the pain, the onset of the pain, when did that pain start? Is it sudden? Is it gradual? Has the patient ever experienced such pain before? Then the character of the pain, what is the pain like? Which words will the patient use to describe the pain? Does the pain radiate anywhere? That's radiation. Then associations, are there other symptoms that are associated with the pain? Because these other associated symptoms could actually tell you the pathology you're dealing with. If someone has abdominal pain, nausea and vomiting, constipation and abdominal distension, you're already thinking towards obstruction. The time course of the pain, is the pain following a particular pattern? Is the pain worse at night, during the day? Are there exacerbating and relieving factors? And then the severity of the pain. So the severity is coming last, because when you now ask how bad is the pain is when our pain assessment tools are coming in. Now, remember, when you're questioning the patient, a lot of patients will have used over-the-counter medication or medications that have been recommended by their family or friends, some leftover medications of a relative. So you need to know if they've used any medication. First of all, was the medication prescribed? Was it bought over the counter? What is the frequency of that medication? Are they taking 1 times 3 Kenyan style, which is morning, lunch, and evening, and you find it's really not 8 hourly if you were to be strict on the time? Then what is the type of medication that they're using? Are they combining the medications? Are they using an opioid and NSAID? And has the patient experienced any side effects? Now, there are some patients who have had pain in the past. You might meet them and it's not the first time they're having pain. So they might tell you, this is the medication I use and it relieves my pain. You actually want to probe further and know what their experience with pain medication has been in the past, and even which kind of medication they have been using. Patients who have used opioids for other reasons, for other pains maybe that they're not presenting with at the time you're reviewing them, you'll find, of course, the patient already has tolerance to opioids, therefore you might need to prescribe higher doses or stronger medications. So it's very important to take a medication history. Now, this sounds very nice and very informative that you can gather all this information from a patient, but sometimes the patient might not be in a position to give you the information. So we have patients who are cognitively impaired, some with learning disabilities. We have patients who might be sedated in the ICU or in operating room settings. We have children. They're not going to give you information. This information that we are asking, when did this pain start, where is it radiating, you might actually not be able to gather all that information. So we'll look at how to assess pain in these populations and how to know how best to manage their pain, because the aim of assessing is for you to choose the correct intervention. Now, pain is more than just physical, especially us who are working in palliative care. When we are assessing pain, we have to assess it in totality. And there's the concept of total pain, which is applicable to patients with life-threatening or life-limiting illnesses, and also patients who have had chronic pain. We want to know the other aspects of this pain. So you have physical pain, but how is it affecting your thoughts? What are you thinking about your illness, about your pain? What is your family thinking? How is it affecting your social life? What does your culture say? Does the patient believe that they have been bewitched or that their neighbor looked at them badly? Do they believe it is demons? You need to find out these issues. This is more applicable for patients with cancer pain and chronic pain, because for acute pain, most of the time we are able to identify the cause of the pain. we are able to treat it and we are able to relieve the pain. But sometimes for chronic pain or cancer pain, we are not able to treat the underlying condition. Therefore, even as we prescribe the pain medication, we still need to give the patient support to actually cope and learn to live with their pain, or rather with analgesics. Now we are going to look at the scales or the pain, let me call them pain assessment tools. So when you're choosing a tool for assessing pain, first of all, you need to select a scale or a tool that is suitable for your patient. So what are your patient's cognitive abilities? What is the age of the patient? And also, what does the patient prefer? We have some simple tools like the numerical scale, which is just rate your pain from 0 to 10. Then we have some questionnaires that might have a couple of questions, maybe 12 to 20 questions. So there are some patients who might not really want to start ticking boxes when they're in pain. They would just prefer to tell you, this is how bad my pain is. Teach the patient to use the scale. Of course, when the patient is in pain and a lot of pain, you want to make it simple. But after relieving their pain, you can still take them through the scale so that now next time it's easier for them. And where you have an opportunity to teach the patient before the pain is expected, such as preoperatively, please teach them how to use the scale. Use the same scale with the same patient each time you are assessing pain. We don't want to confuse the patient so that they give us conflicting answers, and we actually want to make sure that the patient is pain-free. So pain rating scales can be classified in two ways. First, we can look at it as the self-reported scales. As we've said, the patient is able to give us information about their pain. Then they can be behavioral scales. For the special groups of patients who cannot communicate, we are able to observe their body language or their some signs, and we can be able to kind of give a value or estimate how bad their pain is. Then now we can also look at pain scales as a single dimensional or unidimensional or multidimensional. So unidimensional means they're only looking at one aspect of pain, and most of the time they're just looking at the intensity. Then multidimensional, of course, are looking at more aspects of pain. And some of the scales that are multidimensional will go through the first two, the Mcgill and brief pain inventory later. And for neuropathic pain, we have a presentation in February. So the scales for neuropathic pain, we will capture them when we are looking at neuropathic pain in specific. So this is a visual analog scale. It is a 10 centimeter line with 2 points. The point on the extreme left is no pain, and the one on the extreme right is pain as bad as it could possibly be. So the task here is to ask your patient to choose a point on this line that corresponds to their pain. Now, even yourself, if you look at this scale, that seems like a hard task. It's easy when you have no pain or when you have very severe pain. But when your pain is in between, you do not know whether to lean towards the left or the right. So the verbal descriptor scale was an improvement on that one. It added terms. There was pain, no pain, mild, moderate, and severe. So it uses very simple terms for pain rating. But now the problem again comes after severe pain. We have very severe pain and worst possible pain. It is very hard for a patient to decide whether their pain is severe, very severe, or worst possible pain. And patients who will choose anything from severe to worst pain, if you give them the numerical scale, they'll tend to choose for you the region that corresponds to severe pain. The numerical rating pain scale, we use it a lot. It's very common. It's also an 11 centimeter line, so it is from 0 to 10. And it gives values to pain. So you ask your patient to choose a number that corresponds to their pain from 0 to 10. Now, this scale is useful for children from 9 years who are going to school and know how to count, and literate adults. If you give it to an illiterate person, they don't understand the rule of numbers, that 0 is less than 10 or vice versa. So they'll be a bit confused. So we tend to use this for people who are educated and know how to count. So 0 is no pain, 1 to 3 is mild pain, 4 to 6 is moderate, and 7 to 10 is severe. Now, of course, when we go to choose pain interventions, we correspond this to the pain management ladder. Again, it's easy for some patients to rate for you their pain and rate it accurately. But remember, we said pain is more than just physical. Sometimes even ourselves, we branded patients and said they have psychological pain. This pain is not real. Okay, psychological pain is also real. If a patient is presenting with physical pain, or you feel that you don't believe this patient has physical pain and it's a psychological problem, they need a psychological intervention. They need to be linked up to a counselor, a psychologist to sort out those psychological issues. But for severe pain, you could ask extra questions. If you're not convinced, a patient tells you they have severe pain, but you're not convinced that it is severe pain, please find out about their activity, their mobility, their sleep, their feeding, because severe pain will interfere with activities of daily living. So if the patient tells you they have severe pain, they're not sleeping at night, they're not eating, it's true it is severe pain. But if I tell you I have severe pain, but I'm sleeping through the night, my activities are going on as usual, of course now we want to explore what sort of pain does the patient have and how can we help them. Now, pain assessment in children. Remember, we said assessment should be self-reported. So even the child who has pain should report their pain. But it's a bit tricky for children because they're not willing to report that they have pain for various reasons. Some of them are frightened of talking to doctors and nurses, and mostly because every time they see you, you're inflicting some pain on them. Children are frightened of finding out they're sick. Some of them do not want to disappoint or bother their parents or caregivers. A child might have had their mother planning for a safari or planning for something over the weekend, and now they're sick, so they feel if I say I'm sick or I'm in pain, then I'll interfere with my parents' program. Of course, children do not love injections, neither do adults, but again, children are more afraid than us, so they'll tend to withhold information. Some of them do not want to come back to hospital or to delay their discharge process. So when you ask them, do you have pain? They'll tell you no, even when their facial expression can show you they have pain. And again, saying they have pain might lead them to be given medication with unbearable side effects or might lead to a painful procedure. So once they learn that, then again, it becomes difficult. But we are still able to assess pain in children. It doesn't mean that it is impossible. First of all, engage with the child. Don't go to the child's bedside with a child has come to your clinic and you're asking the mom, so how is the pain? Is the child sleeping at night? Engage the child. Have a conversation with the child. They'll tell you how their pain is. Observe their behavior and their physiological changes, if any. And children from the age of 3 years are actually able to communicate about their pain, and they should be given a chance to do so, and they should also be given an age-appropriate tool. As I said, the numerical rating scale, we start using it from children from 9 years and above, and this has been validated by research. And from 3 years to 9 years, we can use the Wong-Becker Faces Scale. So we have 3 main scales or tools that we use to assess pain in children. The FLAC scale is a behavioral scale. So this is for children who are not communicating or infants. So we are able to observe their activity, their face, legs, activity, consolability. We are able to observe that and then rate their pain. Then we also have a touch visual pain scale. Again, this is for children who cannot communicate and for infants. Then we have the Wong-Becker scale for children who can communicate, and the numerical scale for older children. So the FLAC scale, you indicate a score on each of these parameters. So when you want to use a pain assessment tool, make sure you know how to use it, or rather you know how to interpret the scale, even how to use it. So as much as you will teach the patient or you will use the scale, even yourself, you need to know how to use the scale and how to interpret. So we look at their facial expression. So we are dealing with infants here or children who cannot communicate. So what is their facial expression like? Are they smiling or they just seem comfortable? Do they have a frown? Do they look disinterested or do they have a grimace, or are they clenching their jaws or quivering chin? So you choose between number 1 to 3. Then you come to the legs. Is it normal position or relaxed? Uneasy, restless, tense, or are they kicking or drawing up their legs? Then what is the activity of the child? Is the child lying quietly in a normal position? Are they squirming? Are they, do they seem tense? Are they rigid or just refusing to move? Then is the child awake or asleep? Are they crying? And is that crying even screaming? Because for children in pain, they will be screaming throughout continuously. Then now the child who is crying, can that child be consoled? Maybe if their mother reassures them, are they keeping quiet or are they just difficult, impossible to console? So of course, when you come to tally your total score, the lowest score is 3 and the highest is 9. So of course, a higher score means the patient has a lot of pain and a lower score means there is no pain. This touch visual pain score is almost the same as the other one. So of course we look at, we basically are looking at the behavior. So again, what is present? You score 1. So toes bent down or upwards and tense, knees tightly together or crossed, one leg protecting the nappy area. The breathing, is it irregular? Is it normal? Is the heart rate increased? Are the arms tight against the body? Is the child throwing fists? The neck, how is the neck positioned in comparison to the shoulders? Is the head asymmetrical? And what is the facial expression of the baby? So this one, we tend to use it more in neonates and the FLAC in older children. And then the Wong-Becker scale, as I said, from the age of 3, we are able to use this scale. And it has been researched actually since 1987. And it's been shown that it gives accurate assessment of pain among children. So introduce the scale to the child and explain to them that this scale is to help them rate their pain when their pain is worse or at the worst. And please reassure the child that you're not going to inject them or inflict any pain, and keep your promise, because children remember. If you need to do a painful procedure, and then do the procedure first and come and assess pain later. Because if you tell the child you're not going to inject them and they choose for you phase number 5, and you inject them, tomorrow when you come to reassess pain, the child will choose for you phase number 2, or will even refuse to interact with you. So again, create rapport, show them and ask them which phase corresponds with their pain, not their mood. Because sometimes you can find a child in crying because someone has taken their toy, or they wanted something that has not been given to them. So make them understand that it's about their pain, and let the child choose for you a phase that corresponds to their pain. I have used this scale myself very many times, and children give me an accurate description of their pain. So don't be afraid to assess pain even in the young children. They are actually able to give you a very accurate assessment of their pain. When you give them an intervention, they will choose for you again a phase that corresponds with the way the pain is, depending on whether the intervention has worked or not. So 0 is a smiling face. It means, of course, there is no pain. 5 is very severe pain. And then 3 and 4, they are moderate. 1 is mild. 4, here 2 is moderate. So again, you keep using the same tool, and sometimes this Wong-Becker scale, we use it also for illiterate adults or elderly patients who are illiterate. Now we are going to multidimensional instruments. The ones I have projected, you've seen the focus is really on the severity of the pain. So just from the scale or from the assessment, all you will be able to say is the patient has severe pain. You might not be able to say anything more than that. Now, the Mcgill Pain Questionnaire assesses several dimensions of pain. There's the sensory, the affective, and the cognitive. So it has 20 different categories to describe pain, and it uses different groups of adjectives to try and describe pain. So I will project the questionnaire in a bit. So those words are grouped together depending on which aspect of pain they are describing. So some categories include constrictive or pressure. Then there is neuropathic pain. You'll find terms like shooting, stabbing for neuropathic pain. And then there's the affective bit of pain, which is used to understand how an individual patient's pain changes with time. Then, of course, there's also the evaluative portion, where there's about 6 questions that ask the patient to describe their pain. So the interpretation, there's a long version of the questionnaire and a shorter version of the questionnaire. So once the patient has chosen the grouping of words that are corresponding to their pain, you will now assign a numerical score. There's a pain rating index that comes with the questionnaire. And of course, the highest score is 78. And the higher the score, the more likely your patient has pain. Now, there are 2 problems with this questionnaire. First of all, it is long. So a patient who has pain might not really cooperate with filling a questionnaire. So this questionnaire is mostly used in the research setting. Then there's another problem. If you're not an English speaker, it's not your first language, some of these words are actually confusing because the patient needs to come and look at these words and give them a score. So flickering, quivering, pulsing, throbbing, beating, pounding. Someone might not know the difference between throbbing and pounding. And even if they asked you, you might also be unable to explain what the difference is. There's tingling, itchy, stinging. So the basic idea is to kind of start to get a character of the pain by using adjectives. So the patient tries to choose here adjectives that are describing their pain. So in theory, it is good. Practically, I have not seen it being used. The brief pain inventory is another questionnaire that is multidimensional. So it assesses severity of pain and the impact on function. So it's actually very good when your patient is rating their pain maybe at 7, there is extra questions here that will tell you the impact on their function. It's also available as a long or short version, but we use the short version because it has just about 12 questions. So items that assess pain start with how, if the patient has ever experienced pain in their life, then what is the worst pain in the last 24 hours they score, the least pain in the last 24 hours on average, and at the time when you're assessing them, how is the pain? So the patient gets to score their pain at least 4 times. So it gives you a pattern or an idea of the pain. Then there is a bodygram for the patient to draw for you the area where their pain is, and even to indicate this pain in my chest is 10/10 and the one on my back is 5/10. Then there's a section for pain medication if the patient is taking any medication. Then we look at now interference items. What is the pain interfering with? There's general activity, there is mood, there is walking ability, then there's normal work. What work does the patient do, including housework, then relationship with other people, sleep, and enjoyment or overall quality of life. So the questionnaire looks like this. This is the short form. So the patient responds, of course, there are some questions for yes and no. The bodygram, they indicate, they put an X in the area where there's the most pain. Then they rate for you the pain from 0 to 10. So it is also using our numerical scale. So of course, this tells you this questionnaire is for people who are literate. Then, of course, they describe their pain in the last 24 hours at the worst, the least, average, and at the time of assessment, the treatment they are on, And if the treatment has provided relief, again, they rate it from 0 to 100%. Is that medication relieving them completely, moderately, or not at all? Then now the next section from number 9 is now about activities. How is this pain interfering with your activities in the last 24 hours? General activities, mood, walking ability, normal work, relationship with others, sleep, and enjoyment of life. So of course, again, when we are interpreting this brief pain inventory, you look at the responses from your patient and you're able to tell where their pain lies. Is it mild, moderate, or severe? And what interventions might be suitable for the patient. So this has been used more than the Mcgill questionnaire, and it actually even helps us to probe further the other aspects we are saying that we need to assess when taking a history for pain. It will remind us to do that. If someone says that this pain is completely interfering with their enjoyment of life, it will probably to find out what are these challenges that the patient is having. Now, special populations are children, cognitively impaired adults. Then we have adults whose cognition is impaired temporarily by medication or illness. We have those with learning disability, and we have patients who are sedated. So again, today we've only covered how to assess pain in children and the ones cognitively impaired adults who are not communicating. Pain assessment for patients in ICU or in operating room, or those who are sedated or impaired by medication, is actually a lecture by itself. We'll organize that with the anesthesia team. So, of course, after taking your self-report, then you also need to look at nonverbal indicators for pain. As I said, the patient who tells you that they have severe pain, but I tell you I have severe back pain, but I'm able to sit for 30 minutes as we interact. My facial expressions are not showing any pain. Of course, you want now to figure out how to help this kind of patients. But usually facial expressions help us a lot in knowing a patient in pain. Some will frown, some will be blinking, their mood will be distorted. Then there is vocalization. Some patients are even irritable. They're wondering, why are you asking me so many questions and I'm in pain? Then there is the vocalization. Some patients will cry, moan, groan, shout. There might be some breathing that is telling you this patient is in pain. Then we have their movement, body movement. Someone might be guarding, they're rigid, tense, or trying to not use a limb, they're limping. You know, they do not want you to touch a specific area of their body. So the nonverbal cues also help us to affirm the assessment or the self-report that the patient has given us. And we also have some physiological indicators, especially for acute pain or for severe pain. Your patient might have changes in their pupils. They might be increased perspiration, increased heart rate, their breathing pattern has changed, their blood pressure, urine output, their basal metabolic rate. So there are other ways to look at the patient and actually be convinced that they are having pain. Some of them will even have decreased oxygen saturations. They might be flushed. If they are light-skinned, you might see that their skin is even changing. They might have decreased vagal tone and even changes on the EEG sometimes. So sometimes just observing the patient can tell you that they have pain or discomfort that needs to be addressed. Cognitively impaired patients will not verbalize that they have pain, but they may groan or cry. There might be changes in their sleeping rhythm, changes in their activity level. They might just appear to be agitated. There's rigidity, there's clenching of fists. In this population, it's actually very hard to assess pain. For example, for patients with dementia, sometimes what tells you a patient has pain is just their activity level and the change in sleeping patterns and this agitation. And it's very hard to know even whether the discomfort is pain or there's just some overall discomfort. So sometimes in this population, you'll find that we are prescribing analgesics, but maybe there was a bigger issue than just pain. So it's very good when you're assessing cognitively impaired adults to actually do proper assessment and to have wider thinking than just pain, because the same patient could be agitated because they're having a fever or an infection. So it's always good to take a good history, do a good physical exam, take your vital signs, and just observe the patient properly. So if there are any behaviors that also indicate localized pain, like someone rolling their head from side to side, lying with the legs flexed on the abdomen, limping, refusing to move a body part, lying in one position, you want to see what is the overall behavior telling you about where the pain could be. Because we also know sometimes there is referred pain. So the problem might not be where the pain is, but it's referred pain. So it's good to observe if there is any pattern that makes sense of the origin of the pain. Now, I've talked a lot about how to assess pain. For a patient presenting in pain, you want to do a rapid assessment, relieve their pain, and then now start taking a proper history about this pain. I'm thinking about someone who has pain that is 10/10, and I'm giving them a questionnaire asking them, how has your pain been in 24 hours? And I can visualize someone who is already getting upset because they feel you are not taking my pain seriously. So please try to of course, intervene as soon as possible before you take also this very extensive history. It's good to assess the pain properly, but also remember to relieve the patient's pain. Now, after you've started treatment, of course, you want to look at, is there improvement in behavior following the analgesia? Then the medication you've given, think about that medication. Is that medication what the patient is going to be on? What is the likely diagnosis you're going to find? What is the effectiveness of this medicine and how available is it, even outside the institution where you are giving the medication? Then we talked about securing the family's involvement, and of course, seek consent from the patient first before you start discussing issues with their family, even if they're the people who brought the patient to hospital. Find out how they're related and if the patient would actually wish that information should be shared with them. Sometimes it's important for the family to be involved because they're the ones going to take care of the patient at home. But sometimes the patient might not want their family involved, especially in acute things that can be treated and managed. Then anticipate and prevent pain. Identify patients who are likely to suffer from pain, chronic pain or long-term pain, and let those patients be on constant analgesics or constant pain management plans. So a pain management plan is not even that a patient is taking analgesia every day, but the patient knows what interventions exist and how to get those interventions, or even where to get help in case they develop pain. So we are talking, of course, about improved behavior following an analgesic. And even for patients where you think the pain is psychological, we've seen some patients come to the clinic saying, I have a lot of pain. As soon as you put them on the couch, they start sleeping. The pain is over. So sometimes there's psychological and social issues. This behavior also helps us to know what interventions our patient needs. So I would like to stop the presentation there and hand over back to the moderators now for the Q&A session. Thank you for your attention.
Thank you so much, Dr. Nafula, for that session. Very informative on pain management and the various modalities and how we can measure pain. It's been very informative, and I'm sure that you've all learned, picked a thing or two in regards to how to manage, how to pick up pain, how to manage pain, and what needs to be done. It's a very important session, and this is one of the things that usually, even as clinicians, we miss. We treat everything else, but as long as the patient is in pain, they're not comfortable, they're not be able to, I'm getting a bit of panic. You'll not be able to say that they are well. As long as they're in pain, they have not been seen. And it's a very important session. We welcome you, all our participants, to give your questions on the Q&A section. Let me see what we have here. a question from Shindor, which I think is more clinical. I'm not sure if we'll be able to answer this here. I have a patient who complains of left arm radiating to the chest, but at the same time affecting the left foot too, with knee involved. Most of all the pain settles under the left chest cage. And for this one, even before giving to the doc, this one is more clinical and this patient needs an evaluation. In this session, we are talking about how to manage the pain itself, but maybe doc, you can be able to say something in regards to that.
I agree that patient needs a proper pain assessment, because pain that is starting in the left arm, going to the chest, the foot, the knee, it's even hard to predict the pattern of that pain. So that patient just needs a proper assessment of their symptoms clinically, so that we see where the problem is arising from. So sorry, I'm not really able to respond to that, except let's assess the patient first properly.
Yes, indeed. Another question here from, this is George Kema saying the Baker scale is the best. Okay, that's good. Imran Kares, do dental procedures and a local sedation have a way to assess pain besides grimacing? This question is for the dentist. Okay, so any response to that?
I think even the question has been directed to the dentists. Are there any dentists who can help us to be able to assess pain?
Yeah, any dentist, you can comment in the section and in the Q&A section, and you'll be able to read out the response. The EEG means electro. Wait, is it not coming to me? I'll get back to you in a bit. From Zakaria Kimengich, good presentation, Dr. Nafula and Zakaria. And the question is that, do we have this pain assessment guideline tool in our hospital? And if it is it being used?
Sorry, Doc, I didn't get the question.
The question is, do we have the pain assessment guideline tools, guidelines and tools in our hospital, and is it being used? Do we have it here? Is it being used?
Okay, we don't have a pain assessment guideline. Actually, we are still working on the pain management guidelines. Part of the guideline has an assessment. Once it is ready, we will share out. But specifically for pain assessment, we don't have for now. But within the pain and palliative care unit, what we are using for pain assessment mostly is the numerical rating scale and the Wong-Baker scale. That's what we are using to assess pain. It's part of our assessment form, but formal guidelines within the hospital, not yet.
Okay. From Rafael Langat, some pains appear very internal. How do we assess that? Internal pain. I'm trying to get the question right.
Internal. I think the principles of pain assessment, just to make it simple, is take a good history, ask questions about that pain, examine the patient and try to investigate. That's the principles of pain assessment. But I don't know what he means by internal pain.
Maybe it's a bit more psychological, maybe for internal pain, because I'm imagining that some of this pain, I don't know, it affects someone psychologically, or maybe you can have some kind of psychological pain. Maybe we may need to refer the patients to for further assessment psychologically.
Yes, and also, as I mentioned, if you notice that the patient has other pain that is not physical pain, so the patient might have come saying, yes, I have abdominal pain, but after assessing them, you feel, okay, there's more of psychological problems than there is physical pain, then we need to link up the patient with the relevant people to sort out that pain. If someone believes their illness is being caused by demons, the best people to help that person is a chaplain. So we just assess properly and then link up with the relevant colleagues to sort out whatever aspect of pain we have picked out.
Sure. From James of Caretakers on the pain meds, I believe there'll be the further sessions that you'll be able to go more deeper into the medication.
Sorry, Doc, your mic is low. We cannot hear you.
Sorry about that. Are you able to get me now?
Yes.
Oh, okay. So I was reading this comment from James Okech saying, take us on the pain meds. But I'm sure there are other sessions in which you'll be able to delve deeper into the pain medications.
Sure, yeah.
Yes. From Cliff Randa, this is a good presentation. Is there laboratory chemical mediators that can be screened to assess the degree of pain?
The best person to tell you the degree of pain is actually the patient, because even if you did a lab test, for example, and mostly I'm not even sure what you would find, but we have some pain mediators. So even if you found they were high, the self-reported assessment, and the self-report is coming from the patient, is the most accurate way of assessing pain. Because you see, we've gone through a lot of tools and a lot of questions that actually help you to make a judgment about the degree of pain. So I would not rush for those chemical mediators. They exist, but for pain assessment, the best is just you and the patient, interact with the patient.
Sure. The best is to speak to the patient.
And get the answers.
That's the emphasis. Thank you very much for that. Others, Lilian Kabui, thank you. You're saying great presentation. Ruth Moga, very well done presentation. Thank you for joining in and for those congratulatory messages. We have Mary Adalo. How do we manage arthritis pain? Uses diclofenac but is now resistant. So maybe the question here, Doc, is how do you the scaling up of the medications? I'm not sure if this is in this session or in the coming sessions.
I think that one, let's do it in the coming session. We look at pain medications, and because that's really a session by itself. How to choose the pain medications after assessing the pain now, which medications fit which criteria, and then of course managing acute pain and managing chronic pain, the principles are different. The choice of medication is also a bit different.
Then from Billy Namai, I have noticed in my practice, especially towards the end of last year, paracetamol has not been effective in managing pain and fever, especially in kids. Could there be an explanation? Maybe a comment on that?
Doc, give me a minute. Give me just 5 minutes. I'm not going to Sorry, Doc, please repeat the question.
The question is, there's someone, Billy Namai, who is saying he has noticed that in his practice, especially towards the end of last year, paracetamol has not been effective in managing pain and fever, especially in kids. Could there be an explanation? I have many thoughts on this, but maybe you can give her.
Okay, the first thought I would ask, what is the diagnosis? Because if a child has presented with pain and fever, the first question is, what is the diagnosis? Again, what is the degree or severity of their pain and the mechanism of their pain? Because that is what determines how you choose your analgesics. So you could be managing pain with paracetamol, it's not working, maybe because the pain is severe, moderate to severe, and paracetamol would work for mild pain. But my first thought is actually we need to look at what the diagnosis is and what the mechanism of pain is, and also even the pain assessment.
Sure. Then, what is the best way to manage pain or rather psychological pain resulting from addiction?
Yes, you manage the addiction, because part of managing addiction is psychological support. So there is the counseling bit, there is the social bit, and then there is the physical bit. So of course, you manage, since the underlying problem here has been identified as addiction, you manage the addiction.
Sure, you manage the root cause, sure. So a lot of comments here saying this has been a very informative session, and we really thank you for that. George Machama, maybe you might need to add, how soon after assessment do you repeat? I am not sure. I think that was a very specific question to one of the presentation, and I can't really get what exactly, maybe you might need to add to the question. Then, if the pain doesn't respond to NSAID, is it due to the nerves?
I think the emphasis here should be just assess the pain well. Now, neuropathic pain, we are going to discuss it in one of the upcoming sessions. But when we are talking about neuropathic pain, of course, the mechanism of pain is a bit different from nociceptive pain. So you find that we need to use more than one pain medication.
Sure.
So if the pain is not responding to medication, we go back to the drawing board. And the starting point is, did we assess the pain correctly? What other aspects are there? What is the character of that pain, the intensity, the pattern, to sort of try and understand the pathophysiology of the pain.
That's a very good. Yeah, going back to the basics and just reassessing again. You have Anne Lumumba who's asking, I have a patient with chronic headaches, tests done, but we haven't been able to come up with a diagnosis. Could I send him over? Yes, you could send him over. Yes, Dr. Nafula.
And where exactly? I think a patient with chronic headaches should be evaluated in the neurology clinic first. Yes. So it would be clinic 17.
Yeah, so bringing over for yes, we need to get to the bottom of why is he having this, the real issue, why is he having this chronic headaches? And I think that's what Dr. Nafula is emphasizing, that we, as we manage the pain, we need to get to the root source so that we can eliminate the pain, the source of the pain. Leonardo Runga, you are responding. We use the Wong-Baker pain assessment tool in KNH post-anesthetic care unit, Paco in theater. That's great. Thank you for informing on that. Penina saying we need more research about the chemical indicators and the assessment scales. Yeah, that's good. You can actually, why don't you challenge, give a challenge to yourself, and you can actually write a proposal and we can get to that. Yeah. Very good presentation. Thank you. From Dr. Dawa, thanks Dr. Nafula for the valuable presentation, better equipped. So I think we are now coming towards the end. Towards the end of the session, and thank you so much for all your questions and your comments. I think one of the questions is how to get the presentation. We usually have the recording uploaded at the KNH website and also at the KNH Research YouTube. So we'll have the presentation there. Also, when the presentation is sent over, we'll have it in our website. Usually we send it in our website as a coded presentation, and you'll be able to ask for the code and you get the access to the presentations, any presentations that you're able to do and you're able to get. I think a question on, I think I've seen one question on the CPD. We'll be able to get all your CPD points, in time through the email that you registered in. And I think, I actually think that brings us to the end of this session. So I'd like to really thank Dr. Nafula. I don't know if Dr. Valerie is still with us. You can maybe give a comment before Dr. Nafula gives her final remarks.
Good evening, everyone. Thank you, Dr. Nafula, for that presentation. I think we are all feeling a bit more informed in pain assessment. Thank you for everyone's participation and have a good evening.
Thank you, everyone, for attending this webinar. We are happy to have hosted you, and we hope that you will start assessing pain well if you haven't been doing so. And if you have been assessing pain, please continue assessing and reassessing. We want to have a pain-free 2022. Happy New Year to everyone.
Thank you so much, and yes, happy New Year to everyone. Please join in the next sessions. We still have more sessions with Dr. Nafula. She has arranged for us very nice topics in regards very nice topics this quarter and in the coming months. So please do join in. In the coming tomorrow, we have at the same time we have innovations in healthcare, our webinar innovations in healthcare, and you'll be able to see the poster on our screens. And on Friday, we're starting again on our experiences in managing COVID-19. It's usually a very informative session. You don't want to miss it. So thank you everyone for joining in. I'm Dr. Karimba from Kenyatta National Hospital Medical Research. Have a lovely evening.